Okay. Oh, I guess I gotta continue here. Ladies and gentlemen, the subject today, I'm sure, makes many of you feel like you're peering into a vast abyss. And when I thought about how to best engage all of you people that I know are super stoked for today's topic, I thought, how on earth am I going to do that? And then it came to me, I should appeal to their inner nerd. So today I'm going to establish myself as nerd supreme. Oh, hang on. Now, why is this not working? There we go. So, to quote words of wisdom from the Hitchhiker's Guide to the Galaxy, don't panic. For today, we're all going to explore the vast unknowns of pelvic pain. So now that I've hopefully got everybody's full attention, let's get started. The end. So I have no conflicts of interest to declare. The objectives for today are focused on interventions for pelvic pain. For anyone participating in the CIPC a week and a half ago, this is in essence a bit like part 2 of Dr. Bodmeroy's talk, which is important as a primer for pain physicians treating patients with pelvic pain. But today I'm going to talk about 3 blocks in pelvic pain that most of us realistically don't perform that often. The pudendal nerve block, the impar ganglion, and the superior hypogastric plexus block. I'll summarize the literature on each and describe the different approaches. And I'm also going to describe the relevant pain syndromes that as pain physicians, we likely should have a good handle on, simply because many of these pain patients will not have a diagnosis when we see them. I will not be discussing myofascial interventions or any of the more common sacroiliac joint blocks that we do. So this diagram in one view visualizes the distinct nervous structures I'm targeting in today's talk. In front of the L5, we see the superior hypogastric plexus. Then in front of the coccyx, the impar ganglion. And in close proximity, the pudendal nerve extending anteriorly. It should be noted that there are also emerging documents or articles being published on the inferior hypogastric plexus block, but this literature is even less robust than the others, so I just haven't included it today. I acknowledge that while interventions are the focus here, it should be said that pelvic pain syndromes are managed predominantly with multidisciplinary care, and interventions should unlikely be offered in the absence of gold standard medical care. For example, hormones in the management of endometriosis, pelvic floor physiotherapy, and psychology care. However, it should also be said that there seems to be a trend in the literature to consider these blocks perhaps earlier than is current practice. And currently it's pretty much as a last resort because many patients with such blocks are able to advance their treatment in other domains with appropriate goal setting. So for example, a block might enable a patient to perform their physiotherapy or to reduce opioid dependency. So a case that I've had this year will highlight diagnostic and interventional challenges. A 41-year-old female presented with spontaneous onset of coccygeal pain after a walk 3 years ago. She's not a cyclist. She has concurrent history of breast cancer with recent chemotherapy, but no evidence of METs. And she describes pain with prolonged sitting that is burning in nature. It's localized around the coccyx with a slight left more than right sidedness. She's already tried conservative treatment with physiotherapy, not pelvic floor, but regular physio, if there is such a thing, and donut cushion. She's tried NSAIDs, but overall, she's also not keen on medications because of side effects and the localized nature of the pain. So the first pain syndrome I'm going to review is pudendal neuralgia. It's also known as Alcock's canal syndrome, cyclist syndrome, and pudendal nerve entrapment. It's described as a severely painful and disabling neuropathic pain involving the pudendal dermatome. The pain referral can include the rectum, perineum, vulva or scrotum, and even up to the clitoris or penis. It's aggravated by sitting. An estimate of epidemiology is that it comprises 4% of pelvic pain, which is likely an underestimate. The pain with sitting is relieved by standing or laying down, and to distinguish it from other pain generators, these patients often describe having less pain when sitting on a toilet seat, and also less pain on a hard seat compared to a soft seat. Allotriesthesia may be present, which is basically a fancy word for having a foreign body sensation in the rectum or vagina. Bowel movements or urination may be painful. Allotriesthesia, I hope I'm pronouncing it correctly, but yeah, just a foreign body sensation, basically. Pain can also present with intercourse, or other aspects of sex might be painful. Usually there's no sensory impairment. In other words, like there's usually no numbness. Causes. So direct injury to the nerve could be caused by compressions such as with cycling or horseback riding. Transient compression can be caused by spasm of the surrounding muscles, which is usually the obturator internus muscle. It can be difficult to distinguish between patients who have only muscle spasms from those who have nerve injury. And indeed, patients with nerve injury almost always have accompanying muscle spasms. Biochemical or non-mechanical causes of pudendal neuropathy are uncommon, but there are case reports that describe cases that have resulted from viral infections such as herpes zoster or HIV. And also diabetes and MS have been reported. Now, historically, the first identified cause of pudendal neuralgia was cycling, and it was initially called the cyclist syndrome, but the most common cause now considered is pelvic surgery, and especially when using mesh, and then followed by traumatic falls on the buttock and vaginal delivery with or without instrumentation. Other causes of nerve injury or compression could include constipation, anal intercourse, or excessive masturbation. Spinal cord or nerve root compression can occur with cancers, but also benign findings such as Tarlov cysts can contribute. So suffice to say that it's rarely an idiopathic condition, which is important so that we recognize that there's some kind of inciting event most of the time. So this is a nice graphic for reference when trying to distinguish between various nerve contributors to pain. So in the female, the pudendal pretty much supplies the entire perineum, with the exception of the anus, which has overlapping coverage from the coccygeal plexus. And in the male, there is more of an interrupted pattern. So there's this area here, and then the penis, but then the base is not innervated by the pudendal nerve. The pudendal nerve is derived from the sacral roots of S2 to 4, and then later divides into 3 branches. So the dorsal clitoral or penile nerve, which goes all the way to the anterior. Then there's the perineal, which innervates the vulva or the scrotum, and then the inferior rectal branch. It carries motor, sensory, and autonomic fibers, and injury to the pudendal nerve affects both afferent and efferent pathways, but the pain is more common than the motor deficits. And then the course of the pudendal nerve first emerges from the sacrum. So there's branches coming off from each of the S2 to S4, mostly S3, S4 dominant. And it travels laterally and then inferiorly to the anterior surface of the piriformis muscle. So after leaving the inferior edge of the piriformis muscle, it enters the gluteal region where it joins the pudendal artery and vein, which accompany the nerve for the rest of its course. And that's actually a very useful landmark when doing ultrasound guided approaches. The neurovascular bundle travels inferiorly and posteriorly in the fixed space between the sacrospinous ligament and the sacrotuberous ligament, which is more anterior. And at this particular point, the pudendal nerve is the most dorsal structure, with the artery and vein lying anterior to that. And the neurovascular bundle wraps around the posterior surface of the sacrospinous ligament before turning anteriorly and laterally. And this image just gives us a bit of a more close-up view of the nerve as it emerges underneath the piriformis and between the ligaments. So the sacrotuberous ligament is sort of ghosted. And then you can see this sacrospinous ligament underneath. So it's sort of sandwiched in between there. Now, if we look at an anterior view, the nerve, after it crosses the sacrospinous ligament, enters the aponeurosis of the obturator internus muscle, which is commonly called Alcock's canal or the pudendal nerve canal. So essentially it travels three very different regions. And it basically drags across the ischial spine. And one article described it as being straddling this ligament like a violin string on a bridge. And then in one study I looked at, it was pretty cool because they tried to simulate a seated position in the cadaver. And with the seated position, there was ascent of the ischioanal fat, which I'm going to guess is somewhere around here because it applies a sort of lateral pressure to the falciform process of the sacrotuberal ligament. And that basically can put pressure on the nerve in that particular area. And because the pudendal nerve that's contained in the aponeurosis has no place to move, and also higher up, there's no place for it to move up. It gets trapped. So understanding this anatomy from start to finish is theoretically important if you want to understand the potential sites of entrapment. So for example, if the patient sounds like they have pudendal neuralgia with pain referring to the vulva or scrotum, but they don't have pain in the clitoral or penile area, you may want to consider that the entrapment is actually in the Alcock canal and not between the ligaments, because all three branches of the nerve could get squished between the ligaments, but the dorsal nerve of the clitoris branches off before the aponeurosis, so it's spared when the compression is coming from the obturator internus. So in terms of sites of possible entrapment, first, the nerve can become compressed when it comes out from underneath the piriformis. Second, and most common, it can get stuck between or sandwiched between the sacrotuberous ligament and the sacrospinous. So that's the most common. And the third area is the Alcock's canal. And then not on this view, but the fourth area of compression is where the dorsal nerve of the clitoris or penis emerges from underneath the inferior ramus of the pubic bone and turns cephalad. And finally, compression can occur much more anteriorly as well when the dorsal nerve of the clitoris or penis makes an anterior turn to enter the clitoris or penis. So that's quite far forward. Okay. Finally, blocks. I'm not going to be talking about any of the traditional intravaginal or intrarectal approaches, because most interventionists in pain will have one imaging modality or another that's readily available that first is less invasive for the patient and second is safer for the practitioner. The first approach was described under fluoro, in which we look for an AP view of the pelvic inlet, and then we tilt the C-arm 5 to 15 degrees toward the ipsilateral spine until the ischial spine is seen. And that's basically where the needle is placed. So I think this block is perfectly fine for diagnostic purposes, but now I'm wondering if this is not the site of entrapment, I'm not so sure that it would have the same therapeutic value, which maybe we can discuss at the end. Second, as it's relatively high up in the trajectory of the nerve, you may also get a sacral plexus block or sciatic nerve block the day of the procedure. So that could affect their ability to walk the day of. And then overall adverse effects from this block are bruising, infection, and theoretically there's a risk of temporary loss of control of the bowel or bladder, especially for bilateral blocks. However, there are other nerves that concurrently service these sphincters that should maintain continence.
So the final position is dorsal to the ischial spine.
Yes.
Just lay the tip there and you're good to go.
Yes. So 3 ultrasound guided techniques have been described. And this one is likely closest to the fluoro technique because the landmark is still the ischial spine. But this is actually quite nice because you can use the pudendal artery as a landmark in addition to the ischial spine. And further, you can also be quite certain that the needle is placed at the site of most common entrapment, which is between the sacrotuberous ligament superficially and the sacrospinous ligament, which is a lateral extension of the ischial spine when you can see it. Now, if you compare fluoro to ultrasound guided, that might be a question you have. This randomized controlled trial done by our good colleagues in Ontario on 23 patients in 2012 show similar efficacy of the block with no difference in adverse effects. So both groups had similar adverse effects of temporary foot drop in 2 patients in each group. And the time to completion was actually 3.5 minutes longer in the ultrasound group. And keep in mind that this initial ultrasound guided approach used is essentially at the same level of the buttock as a fluoro approach. So this was one of the articles suggested for rounds today, and I think it does add to the options for interventions, especially if one thinks that the entrapment is slightly lower down than the ischial spine and closer to the Alcock canal. So what's the same is that you can use the same approach to find the pudendal nerve as previous. So and in 4A and 4B, you can see the same structures I showed previous. What's different is when you scan distally from the ischial spine along the lesser sciatic notch, that's where the internal obturator muscle wraps around, and that's highlighted by this reddish structure here. And what you're looking for is the point where you get to the coccygeus. I'm not sure if that's how you say it. And you see the obturator internus in the same view. And basically you're putting your needle right beside the nerve at that point. Now, in this article, they used a high volume of injectate of 10 mils, whereas the randomized control trial I just mentioned before was 4. And they wanted to test the theory if this could cause a concomitant sciatic nerve blockage by being a little bit lower down. So they only did it in 3 patients. None of the patients did, however. I mean, obviously the sample size is a problem still. But I do like this thinking because if you're a believer in not just blocking the nerve, but perhaps using hydrodissection with volume at the same time to treat a possible entrapment, then this might be a more effective approach if you think that the entrance to the Alcock canal is where the nerve is being compressed. So this was a case report of 2 successful PRFs in patients with pudendal neuralgia using pretty standard PRF settings. And they had a protocol in which they did the same procedure twice within 2 weeks of each block. And they were able to show prolonged and significant pain relief at 10 months. So I think that's something that, that I guess we can consider. This was one of the articles posted for consideration of rounds discussion today, but I didn't send it to the group. I'm not going to spend much time on this because really it's outside of the realm of possible in Canada to implement, but these guys in the same procedure, same day, harvested adipose stem cells using liposuction, spun down the sample, and then injected the stem cells into the pudendal area with a landmark guided approach. Now, while this is interesting, I think that our other approaches, at least for the time being, are more user-friendly. I can't think that I'm going to take up liposuction anytime soon. And while this is interesting, these guys were very critical of the fact that other blocks have not been able to show effects for greater than 1 year, but in the patients that they did achieve good results in, they also started noticing a trend reversal in pain control by the end of 1 year. So the next pain condition of focus today is coccydynia, which is defined as pain in the terminal segment of the spine. It also worsens with prolonged sitting, albeit usually with more of a leaning back posture. They often describe pain with defecation or intercourse. It is more common in women and in the 4th decade of life. The etiology is usually idiopathic, followed by external or internal trauma, such as with a backward fall or obstructed labor. Other causes can include joint disease, hyper or hypomobility of the sacrococcygeal joint, obesity, infections, and cancers of the pelvis or anorectal area. Treatment is typically with NSAIDs, hot or cold therapy, TENS, topicals, cushions, and physiotherapy. So each sympathetic trunk in the pelvic area is positioned anterior to the sacrum, and they're medial to the sacral foramina. There are 4 or 5 small sacral ganglia, with the ganglion impar being the most caudal segment of the confluence of the sympathetic chain as it passes anteromedially over the sacrum. And more specifically, the ganglion impar is the terminal fusion of 2 chains. And there is some anatomical variability between the sacrococcygeal joint and the lower segment of the coccyx in terms of where it lies. Now, because it fuses, it typically means that it's midline, which makes it a bit or a lot easier to find. But given the anatomical variability, that makes us need to consider the target given the likelihood of where the ganglion impar lies. So the greatest likelihood is at the first discal joint of the coccyx. And then the second most likely region is at the sacrococcygeal joint. So indications for this block can be pretty varied and may include when you're trying to target pain coming from the perineum, the recta, the distal portion of the rectum, the anus, the distal urethra, vulva or scrotum, the distal third of the vagina. And then conditions you might be treating include CRPS of that region, endometriosis, chronic prostatitis, proctalgia fugax, coccydynia, postherpetic neuralgia, and burning localized perineal pain with urgency. So for this block, the transsacrococcygeal approach is the most practical because a straight needle can be used and that decreases the risk of infection. Because historically they had some pretty odd or fancy dance needles with really variable curvatures, and they were trying to hook underneath the coccyx. But basically all of these have been abandoned given how much easier the straight needle approach is. And also there's a decreased risk of rectal perforation with this. So contrast should show a reversed comma sign in the lateral view. Temporary relief with local anesthetic could be followed with either radiofrequency or phenol. If you're considering radiofrequency, one of the papers I looked at encouraged a needle through needle technique because you can damage the Teflon coating of the RF needle with a transdiscal approach. I guess I hadn't heard of that being a problem before. And possible complications include the usual of infection, an intravascular injection, but also given the proximity of the ganglion impar to the rectum, perforation of the rectum is possible. However, no complications or adverse effects have really been reported in the literature from this block. So this was a study looking at the efficacy of the impar ganglion block in patients specifically with coccydynia. There's 35 patients. They used fluoro and they went through the sacrococcygeal joint with a 22 gauge needle through the joint, and then a 25 gauge needle advanced through the 22 gauge. They used a combination of bupivacaine and methylprednisolone as the injectate. And there was sustained pain improvement of greater than 50% at 6 months post-injection. But also importantly, function was improved as well as measured by the Oswestry Disability Index. This study by Usmani and colleagues in 2018 looked at conventional cooled, that is what they're referring to in this conventional RF, versus pulsed radiofrequency in a prospective randomized double-blind study. And this was also a suggested article for our rounds today. They had 34 patients in the cooled RF group versus 31 in the PRF. They used pretty standard RF settings for both the conventional and pulsed RF. And the bottom line really was that PRF did not provide significant pain relief at all. There were flaws in the study. They had a pretty short follow-up period of only 6 weeks, and it was only powered to 80%. But it can also be difficult to acquire volumes of these kinds of patients to do these kinds of studies in the first place. Cooled. Cooled. Yeah. Yeah. Okay. Sure. Yeah. Yeah.
Cool radiofrequency is heat radiofrequency, but you cool the needle in a way that makes the temperature reach out to larger areas. But it still is heat radiofrequency.
Because we discussed in the past the modern ones about the proximity to the rectum and the burn things, maybe to the rectum. To my knowledge, none has ever tried to do beyond here. I don't think that the time
And I typically do,
yes,
but TRF no, but sure we have a case.
But
no, with TRF, because we have tried TRF. No, we have tried it hasn't worked the way we want, so we're gonna try it again.
So the other consideration would be at which level was the needle placed, because I didn't know that before either. Theoretically, phenol should still travel to cover the distance well, but if you're doing an RF approach, I think it would matter more if you're not using a cooled RF approach. Okay, so back to my case. So when I first examined my patient, it really seemed local to the coccyx. There was some radiation forward to the vaginal area. So the first thing I tried was an impar ganglion, which unfortunately at follow-up, the patient said at best 30% temporary benefit. But really, I think she was just being nice, and I don't think she had any meaningful benefit at all. So, and then also during the block, she struggled because she had a significant vasovagal episode. She was nauseated, sweaty, white as a sheet. So as my follow-up at that time was by phone, I felt like I needed to re-examine her again, but she was off kind of doing some important stuff for a few months, like cancer treatment. So I only saw her again 6 weeks ago to re-examine her. But again, I really still felt like most of her pain was centered around her coccyx. So on that day, I attempted a local sacrococcygeal joint infiltration. And 2 weeks ago at follow-up, this too had no benefit. So now that I've done so much review on this topic in the last few weeks, I think at the end of the day, I really missed the boat on a possible pudendal neuralgia. The pieces of her history that I was missing at the beginning was that she has relief of her sitting pain on the toilet. She denies a foreign body sensation and has no pain with BMs, voiding, or intercourse, but she does actually have burning all the way to the front of her vulva that's left side dominant. So I have offered her a pudendal nerve block under ultrasound, but understandably the patient is a bit more hesitant about blocks now. She's going to think about it. I've asked her to revisit pelvic floor physio because she hasn't done pelvic floor physio. And then she also expressed an interest in acupuncture. So the lessons for me here from this case, as always in interventions, are, making sure we select the right block for the right indication in the right patient. So last section of the lecture, Plancart and colleagues described the superior hypogastric block in 1990 and found that sympathetically mediated pain was significantly reduced or eliminated in all cases without serious complications. Now, although this injection was originally developed to treat pelvic cancer pain, As with many procedures that were originally limited to terminal cancer pain patients, these techniques are now commonly used in non-malignant pain. Patients have frequently failed to respond to less invasive procedures such as lumbar or caudal epidural injections. And like other sympathetic blocks, there have not been rigorous testing studies on the safety and efficacy of this treatment approach. So we can really only rely on small, uncontrolled observational trials for hints at its usefulness. So the superior and inferior hypogastric plexuses innervate the lower pelvic viscera, including the distal end of the alimental canal, the bladder, ureters, prostate, penis, ovaries, uterus, and vagina. So basically everything. Now, the superior hypogastric block is an extension of the celiac and then the aortic plexus in the caudate direction. So it's just below the aortic bifurcation. It receives fibers from the aortic plexus, but it also has contributions from the L3 and 4 splanchnic nerves. It's situated on the ventral aspect of L5 to S1 and on the disc between L5 to S1. It's close to the sympathetic chain at this level, and the common and iliac arteries are on either side, and the veins, of course, as well. The ureter is located just lateral to the structures in close proximity to the anterolateral aspect of the L5. As the aorta is shifted slightly more to the left, both actually the superior hypogastric plexus and the hypogastric nerves are slightly on the left side as well. And technically, these nerves, they're not really what's traditionally thought of as a nerve. They're more like a meshwork and not so much solid nerve trunks. The nerve meshwork diverges laterally to the rectum on either side and curves outward and backward as it makes its way downward in the pelvis. They interconnect the superior and inferior hypogastric plexuses, and they contain no ganglia. So I'm not going to talk about any pain syndromes here. Dr. Bodmer-Roy's talk was fairly good for introducing us to that. And also, most patients with a lot of these issues will arrive with these diagnoses to an interventional pain physician. So this block can be considered in intractable chronic pelvic pain for endometriosis, pelvic inflammatory disease, pelvic adhesions. It could also be considered in interstitial cystitis or irritable bowel syndrome, and then CRPS, or of course, pain due to a cancer in the pelvis. Now, if you're doing a diagnostic block of the plexus with local anesthetic and it's positive, it can be followed by a neurolytic procedure, which could potentially provide long-term relief. Complications of the block can include retroperitoneal hematoma, injury to exiting nerve roots or spinal cord, damage to the pelvic viscera, including ureters. You could have an inadvertent intravascular or epidural or subdural or subarachnoid injection, trauma to the intervertebral disc. There could be discitis. And you could also cause acute ischemia of the foot if you were to dislodge an atherosclerotic plaque from the iliac vessels. And transient retrograde ejaculation is also possible. Now, keep in mind, these risks are largely considered theoretical because I didn't come across any reports in the literature of any of these complications. So these are basically the pioneering studies of the different approaches of the superior hypogastric plexus block. The first was done by Plancart using a posterior 2-needle approach. The second by Kanazi using an anterior approach. And the third suggestion was a posterior 1-needle transdiscal approach. So this graphic shows needle placement at the anterior aspect of the L5 vertebral body. And hang on here. I'm going to just actually back up just to describe it a little bit more detail. The classic approach has a patient lying in prone. Needles are placed 5 to 7 centimeters bilaterally of the L4-5 disc interspace, and then it's directed 30 degrees caudate and 45 degrees obliquely toward the midline. Now, the iliac crest and transverse process of L5 can be an obstacle in this approach, and the needle is advanced until the body of L5 vertebra is met, or the tip lies anterolaterally. And we already saw that. Now, the initial study by Kanazi describing a transdiscal technique was performed with a paramedian interlaminar approach. If I was going to consider a transdiscal, given the risk of thecal sac puncture and nerve root damage, I think this update in 2018 would likely be preferred, as it mitigates those concerns with the transdiscal approach while maintaining the benefit of a single needle approach and avoiding the problematic bony structures. So in this update, the entry point for the needle was 7 to 8 centimeters left of midline at the L4-5 level, and it was advanced caudally toward the L5-S1 disc at a 40-degree angle from the vertical plane. Then, using lateral fluoroscopic control, the needle was advanced beneath the inferior aspect of the facet joint. After entering the disc, the needle was then advanced until it passed the anterior annulus fibrosus of the L5-S1 disc. And basically from there, you carry on as usual with the injectate and or phenol if you're doing neurolysis. In this study, they gave the patient 1 gram of cefazolin 30 minutes before the procedure as a prophylactic antibiotic to prevent discitis. Although I think it's a little controversial whether or not antibiotics are absolutely required for this. Now for an anterior approach, which we affectionately call here an STP, or a sphincter tightening procedure. When we first did this in fellowship here, I can say that the idea of piercing through the bowel was mildly nerve-wracking. However, having looked into this in depth now, the chance of complication due to bowel perforation is really quite small. So for one, the needle size is no larger than 22 gauge. Second, the small intestine in the midline is more likely to be affected than the large intestine at this level. So perforation, obviously, of the small intestine carries less infectious risk than of the large intestine. And then third, it's even if you do perforate it, it's considered inconsequential. And that's really based on the interventional radiology literature that's been done on the anterior celiac plexus approach. So this block can easily be done under fluoro, but for variety, I show the ultrasound approach here. The patient is positioned in supine in slight Trendelenburg. A curvilinear transducer is used for sagittal long axis mapping of the L5-S1 disc. And after ensuring only abdominal wall structures are positioned between transducer and the center of the L5-S1 disc, the needle is introduced and you just target the anterior surface of the disc. After you see the tip at the disc, you can inject your analgesic or neurolytic. So these are my references included for anyone who wants to go a lot farther into the abyss. And now I will try to attempt and answer any questions. And because someone might be nerd enough to ask the answer to the ultimate question of life, the universe, and everything from the Hitchhiker's Guide to the Galaxy, first calculated by the supercomputer Deep Thought after 7.5 million years of thought, it's 42.